And then our digestive tracts also are affected to changes due to aging, medications, and diet. We have a slower peristalsis, which is one of the reasons why our residents become more constipated, also because of decreased exercise and medications. And so constipation will be a hot topic for older adults and something they'll probably ask you about quite significantly. The lining of the stomach is unable to resist damage as well because we have that lower acid production. We have bacterial overgrowth. That can lead to lactose intolerance and vitamin reabsorption problems. And our stomach shrinks some and holds less food. So all of these things have an impact on digestion in older adults. We've talked a little bit about testosterone and estrogen levels, and testosterone levels drop, estrogen levels rise over time, and that definitely impacts how different hormones work in the body and can cause quite a significant change in not just the reproductive system, but our entire system as a whole. Our immune system, we aren't able to fight infections, and we have a lower response rate to vaccinations. So let's talk about this a little bit. First of all, our bone marrow produces fewer B cells. Our thymus output produces fewer T cells. And our lymphocytes fail sooner and aren't recreated or reproduced as quickly. So between those three factors, we have a much more susceptible immune system. Our patients really should have vaccinations by the time they're 65 in order to maximize their impact on their body. That's just a good guess because everybody's body is going to change at different time frames, but 65 or before is the best time due to more T cells being in the system to help with fighting infection. So for immunity implications, remember that older adults have a decreased ability to develop immunity after infection or immunization. Vaccinate by age 60 for the best B cell response, age 65 for the best T cell response. Basal temperature of older adults is lower than younger adults, so that means that they can have a low-grade fever. That might signify a serious illness. And lack of fever doesn't rule out infection. Watch for changes in level of consciousness and mental status, agitation, somnolence, pallor, increased respirations. All of these things are time to assess your resident very carefully and try to figure out what's going on. The second part of this lecture is about intimacy and sexuality in older adults, and these are normal health changes, so we're going to consider them in this module. And remember that sexual health is very much influenced by cultural and cohort influences. That means that in whatever era that person was born, influences attitudes about sexuality. It's important to know and understand the person within his or her own background, social and cultural background, and not make judgments. We want to think about redefining sexuality in older persons. Often focuses on shifts from procreation to companionship, physical nearness, intimate communication, and pleasure seeking. It doesn't necessarily involve sexual intercourse at all times. And then expectations, everything from culture, biological, psychosocial, and environmental factors influence sexual behavior. Factors that impact intimacy and sexuality also include family dynamics and upbringing and other cultural and religious beliefs. So we want to think about the different types of sexual lifestyles. Those who are lesbian, gay, bisexual, or transgender are way less likely to seek out health services or identify themselves as that way to healthcare providers. They may have kept this relationship hidden in the past, much more than those younger adults in today's gay liberation movement. There's definitely, as nurses, we need to think and be sensitive to history taking. So you might ask, do you have a significant other? Better than, are you married? You could ask them if they consider themselves bisexual, heterosexual, homosexual, to help convey that recognition of diversity. They still may not tell you, and all of that's okay. I know when I was in my 20s and working in my first nursing home, I had a little old lady who basically asked if I'd come to bed with her. And she was on the dementia unit, so I knew she didn't have good cognition. And I said, well, I don't think my boyfriend would like that very much. And she responded by saying, oh my goodness, that wouldn't work at all. She really wasn't trying to be obnoxious or anything. It is some base instinct that some of those sexual types of expressions come out when cognition starts to drop. And so the being open and honest and redirecting people can all help with that. So if we think about the realities of life in sex in older life, a lot of people have misconceptions that older adults are interested or capable in having sexual intercourse, and a lot of health professionals lack experience in discussing sex with any age group. So it's important to ask about it and get yourself comfortable. Ask these questions to peers, or your nursing student peers, family members if you need to, so that you can ask those questions without turning beet red and getting yourself embarrassed. You also need to promote understanding of older adults' sexuality, so it needs to be open enough. In the nursing home as well, if we had men and women, let's say a couple came to the nursing home, they would never have put them in the same room. They would never have thought about the same type of bed, like a bigger bed so they could both be in bed together. Those things weren't things that the home thought about, even though they were married and would most likely want to be close to one another. Some violations of older adults' sexual identity, denying requests for same-sex aid for personal care, forgetting to button up, zip, or fasten clothing when you're dressing older adults, unnecessarily exposing when you're doing care or procedures, discussing incontinence episodes when you're in earshot of peers, ignoring or belittling older adults' attempts to look attractive, and joking about older adults' flirtations with each other. So biological changes with aging, we've talked about some of these, but for women, menopause, and then women can also get dyspareunia, which is vaginal dryness and thinning of the vaginal tissue, and that can cause pain if they have sexual intercourse. Men can have a change in the firmness of erection. They'll have a decreased need for ejaculation with each orgasm, and that refractory period is much longer between episodes of intercourse. Male dysfunctions, impotence is what you hear about where a male person has erectile dysfunction, or ED, and it's defined as the inability to achieve or sustain erection sufficient for satisfactory sexual intercourse in at least 50% of the time. Usually, in most older men, it's caused by some other medical diagnosis. And there are some treatments like Viagra and some other medications that are now available for treating that. Usually, if we can find the cause, and some of the causes are listed down below, then we can address and correct the issue. So, for example, if someone gets put on an antidepressant, if someone gets put on a beta blocker, those medications will cause erectile dysfunction. Can we put them on a different medication that might be better and have fewer side effects? This is also an area where people are going to be a little bit worried about. And if they figure out that that medicine is what's probably causing it, then they're likely not to take their medicine. And that results in non-compliance of other body systems. Female dysfunction, it's considered a persistent impediment to a person's normal pattern of sexual interest, response, or both. Again, it's influenced by culture, ethnicity, and some other factors. Water-soluble lubricants or low-dose estrogens in the vagina can also help restore lubrication and make intercourse at least a little bit easier. We have a National Gay and Lesbian Task Force Aging Initiative estimates that about 3 million Americans over the age of 65 are lesbian, gay, bisexual, and transgender, and they expect that number to double by 2030. LGBT older adults are less likely than heterosexuals to access health and social services or to identify themselves as that way. And they may face very real or perceived discrimination in senior centers or long-term care facilities. So while we've come an extremely long way, that discrimination may still occur. And in reality, it is the nurse's job to advocate for those residents and help them overcome some of that discrimination. And as I mentioned before, include some open-ended questions. Word your questions carefully as you're doing your health history so that you can get a good assessment that's as accurate as possible. And then to help promote sexual relationships or romantic relationships in long-term care, we can provide some door locks or privacy. We can help with some queen-size beds. There is a specific guideline, Caring for the Ages, that provides some guidelines for sex and sexual intercourse in long-term care facilities if you're interested in more details. That's the end of week 5 lecture. Thank you so much. If you have questions, please do let me know.